Oh.
Good afternoon. Welcome back to Grand Rounds. Please remember to sign the attendance record. Please remember also to fill out the program evaluations, and please also, if possible, give us any ideas in regards to future topics or future speakers. Today, it is my pleasure to have the opportunity to introduce Dr. Tamim Mahayni. Dr. Mahayni is an Ames native and the newest member of the Department of Pulmonology and Critical Care at Mary Greeley and at McFarland. He did his residency and fellowship at the University of Kansas, and he kindly has accepted our invitation today to help us make sense of the alphabet soup of interstitial lung disease. And please join me in welcoming Dr. Mahayni.
Thank you. Can you guys hear me? Okay. Well, thank you for the invitation to talk today. It's my pleasure. My name is Tamim Mahayni. I started here at McFarland and Mary Greeley as the new pulmonologist in August, but I'm not new to Ames. I grew up here, Ames High grad, Iowa State grad, Des Moines University grad, and then went down to the University of Kansas, though let's be clear, I'm definitely not a Jayhawk. And met my wife there in residency, dragged her back to Ames, so she's working in adult medicine now. The reason for the name of the talk, Alphabet Soup of Interstitial Lung Disease, is if you know a pulmonologist or spend any time with pulmonologists, we really spend most of our time talking in acronyms. That'll be more clear later when we talk about the various diseases, but the best example would be something like COPD. We usually save credit for the last, but I want to some of my slides aren't mine. There was a presentation on idiopathic pulmonary fibrosis in Saudi Arabia, and I gathered some of their slides because their diagrams were just much better than anything I could do. So the purpose of, well, I guess let's start to the obligatory. I don't have any financial relationships really with anything that I'm talking about, but I'm open to it if anybody needs. But yeah, no financial disclosures. So the goal for today, when thinking about this talk, is when I hear, it's fairly common for me for somebody to say, well, my so-and-so has interstitial lung disease. And my goal today is to describe what goes on in my mind when somebody says they have interstitial lung disease, because it's a quite broad term. The interpretation I have for that is they have lung disease that's not otherwise COPD, asthma, or lung cancer. So it's a very quite broad term, but it's a difficult thing to talk about because it is so varied, and our audience today is also, very broad over the healthcare spectrum. So my goal today is really to have you learn something or reinforce something you already knew. I do like to break things down into very simple terms. And when you talk about interstitial lung disease, you can't talk about it unless you understand the anatomy of the lung and radiographic terms. For instance, I could talk about somebody who's got ground glass opacities that are subpleural in the lower lobes, and if you don't know what any of those terms mean, then there's no point in continuing on with the discussion. So the first thing I'd like to do is just talk briefly about lung anatomy, and then define radiographic features. Then we'll briefly talk about the various subtypes of interstitial lung disease, and you can see the acronyms there: COP, NSIP, RBILD, DIP, LIP, or UIP, and you'll get the full names later. And then we'll spend the rest of the time about idiopathic pulmonary fibrosis, because we just have more information about that. Roughly about 40 slides to go through. I went through it yesterday. It took me about 40 minutes, but that was with my infant at my feet crying the whole time. So to make me feel more at home, I've asked Gilman to just cry throughout this entire presentation. The material might make you want to do that anyway. But so the anatomy, obviously, we have a left lung and the right lung. The left lung is divided into two segments: the left upper lobe and the left lower lobe. The left upper lobe has the superior segment and the inferior segment, which is commonly known as the lingula, which sits just by the heart. And then there's the left lower lobe, which is divided into basilar subsegments. The right lung has three lobes. There's the right upper lobe, the right middle lobe, and the right lower lobe. And you can see each of those lobes are divided into different segments. When you talk about the bronchial tree, this is, I thought, kind of an obnoxious diagram, but just shows the extent of the bronchial tree and how the bronchial tree just kind of narrows and goes into very non-specific definitions. I like this diagram because when we're asked to do a lavage for somebody who's got a peripheral consolidation in the lower lobe, our scope goes to about right here, and then we shoot saline in this general direction, and so you can see how very non-specific that is. An easier way to look at the bronchial tree is just something like this, where you have the trachea, the bronchi, the bronchioles, the terminal bronchioles, and then you've got what we call the conducting zones, which is where gas exchange occurs, where the respiratory bronchioles, the alveolar ducts, and then the alveolar sacs. That's just an easy way to define one tract of gas exchange. When you get down to the alveolar sacs and then to the lung parenchyma, what's important to know is that the bronchioles travel with the pulmonary arteries into the interstitium where gas exchange occurs. The interstitium is surrounded by interlobular septa, which is where the pulmonary veins and lymphatics are, and then you've got the visceral pleura as well. So that's a very, very, very basic guide to pulmonary anatomy. When we talk about radiographic definitions, I apologize for any radiologist who may be here because I break this down into very, very simple terms. This is a CAT scan of a lung. The left lung appears here, the right lung appears here, and for the most part, this is just one cut, but this is what we call a normal CAT scan. The consolidation is really, you can see here, the obvious abnormality here. It's defined as small airways and alveoli that are filled with fluid rather than gas. Could really be anything: pus, blood, inflammation, edema. And the diagnostic characteristic is the air bronchogram, which is that large airway visualized through consolidated lung. So there's the airway that you can see, but you're not supposed to be able to see that. So you see that airway going forward, and then this is all consolidated lung. So again, we're just reviewing basic radiographic terms here. A ground glass opacity is what I basically describe to patients as chalk on a chalkboard. And so you can see this is normal lung, and this kind of increased attenuation with preserved bronchial and vascular markings. What that really means is that you can still see blood vessels underneath. So you can see how that's different from a consolidation. It's really defined as incomplete filling of the alveoli. Very nonspecific finding, but something that's obviously different to us than a consolidation. A nodule, we see these all the time. A very simple thing to see right here. Just easily defined as a rounded opacity within the interstitium. Technically, anything less than 3 centimeters is a nodule. Anything greater than 3 centimeters is a mass. The elephant in the room is we always want to know if these are malignant or not, but malignancy isn't always the answer. These could be infectious or inflammatory, or just something related to exposure. Bronchiectasis. Again, you shouldn't be able to see the airways going as far out as they should. And so bronchiectasis is defined as abnormal dilation of the bronchial tree. There's a significant number of causes. The most common is either just idiopathic or somebody who's had recurrent infections, and it's just that the dilation is just destruction of the airway. Cystic fibrosis is well known, but not that common here anyway, at McFarland. Can look like that too, and that some other genetic diseases. Obstruction, malignancy in foreign body, and that's again just from repeated trauma to the airway. And then some autoimmune diseases, which it's intimidating to talk about with Dr. Gearbrocht in the room. But going forward, honeycombing is going to be an important concept for us going forward. And you can see the extent of honeycombing in this CAT scan. It's this top image here, and it's all this cystic-looking stuff. So it's defined as clustered cystic air spaces, generally at the basis, and it's very characteristic of fibrosis. Severe emphysema can generally look the same way. Reticulation is a very non-specific finding on a CAT scan. A lot of times it's overlooked because it clinically usually doesn't mean anything unless it's coupled with something else, but you can see they're trying to circle it here. There's just this linear opacification. They're usually quite subtle. So we've defined the anatomy, we've briefly reviewed radiographic terms, so now we're going to keep that in mind as we look at the subtypes of interstitial lung disease. And these are the names of them, and so now you can understand why pulmonologists prefer to use acronyms, because I don't want to walk around saying respiratory bronchiolitis associated interstitial lung disease, or lymphocytic interstitial pneumonitis, or, you know, so that's why we use COP, NSIP, RBILD, DIP, LIP, things like that. So this is what we're going to talk about, and we'll end with more on usual interstitial pneumonia. This is just a different way of looking at it, because obviously interstitial lung disease, like I talked about, is a quite broad term, and I like this graph because this is one that really helps organize your thought process. So it's a classification of interstitial lung disease. Interstitial lung disease can be caused by something. Connective tissue disease, so rheumatoid arthritis associated interstitial lung disease, scleroderma associated interstitial lung disease. Drugs, we can talk about amiodarone associated interstitial lung disease, erlotinib associated interstitial lung disease. Exposure, things like hypersensitivity pneumonitis, which is generally an exposure that causes somewhat of an allergic reaction. We're going to spend most of our time on the idiopathic, meaning we don't know interstitial pneumonias. So we'll spend most of our time talking about these, but most of our time talking about this. And then we've all heard of sarcoidosis, which is a talk in itself entirely. Generally, we don't know the cause of it, but it's also considered an interstitial lung disease. And then there's some very, very, very rare stuff that generally one person at Mayo has a clinic every Thursday to evaluate for, and that's things like LAM, which is a cystic lung disease usually seen in women, pulmonary Langerhans cell histiocytosis, pulmonary alveolar proteinosis. So again, you can see why we use acronyms. Those are hard terms to just repeatedly say over and over again. And then there's the rare stuff. We'll talk a little bit about this. The overview of the workup, I say they're all they're nuanced and different in their own respects, but the workup for these, from my perspective, is generally the same. What you really want to do is define any exposures they may have had, look at their medication list, both now and in recent history, look at their occupation, look at their environment, evaluate for any connective tissue diseases, evaluate for sarcoidosis, and if you can't find anything, that's when you're down in this idiopathic category. So you really, as with anything that we do, history and physical, history and serologies really help. The question we always get is, when should we bronch and when should we proceed with a surgical lung biopsy? The answer I usually get is, if I can't identify what's going on based on the history and their labs, for instance, it's somebody who has rheumatoid arthritis who now has interstitial lung disease, well, it's probably that. But if you can't define what's going on, that would be a time to bronch to get cell counts, especially if infection and malignancy are still in the differential at that point. When to pursue biopsy? Well, generally if you're still at the end of the algorithm and you don't know what's going on, and bronchoscopy hasn't helped. In terms of biopsy, everybody has their own style. If you look at the literature, transbronchial biopsy is generally unhelpful given the size and the patchy nature of interstitial lung disease. So generally open lung biopsy or a VATS type biopsy is preferred, and actually different biopsy sites are preferred just because of the patchy nature of it. The treatment, I'm not going to talk a lot about treatment of interstitial lung disease. Frankly, there's not a lot of data. If you look at data about treatment for interstitial lung disease, it's generally based on less than 50 people per study, and it's hard to extrapolate that. Everybody's a little bit different, but basically the treatment is stop the offending agent and or avoid the exposure, evaluate if it's something that's generally prednisone responsive or smoking related, and we'll go over that a little bit. Immunosuppression, Imuran, Celsep, cyclophosphamide, rituximab. In the interstitial lung disease world, there's just not a lot of data to say we use this for this type of thing. Everybody has their own regional proclivities as to what they use. So a high-resolution CT scan, what is it? Well, it's the mainstay of evaluation for somebody with interstitial lung disease. And what it really does is it gives you thinner cuts of the lung parenchyma, so you get a better evaluation. of the tissue. They also do inspiratory and expiratory cuts. Expiratory cuts really help potentiate air trapping if air trapping exists. But more importantly, they do supine and prone imaging. And the reason for that is when you're laying flat, sometimes you can get just atelectasis, which can mimic something like subpleural reticulation at the bases. So if you lay somebody on their stomach and repeat the CT scan and have them take a deep breath, that may go away and they don't actually have interstitial lung disease. So it's important to get a high resolution CAT scan. So we're going to do a slide per interstitial lung disease and just kind of run through this so that we can end up with usual interstitial pneumonia or idiopathic pulmonary fibrosis. So this is cryptogenic organizing pneumonia. Generally, this case is a flabbergasted infectious disease doctor who's dealing with a patient who's had migratory consolidations, fevers, chills, but just can't find the infection and it's not really responding to antibiotics. The symptoms are generally subacute, and the imaging is migratory patchy consolidation. So think back again to our radiographic terms. That's a consolidation. There's an air bronchogram. Can be idiopathic, can be caused by drugs, autoimmune, or occupational exposure. Pay attention to the etiology on all these slides because for the most part, the etiology could cause any one of these things. If you do take a biopsy, and this is one that we generally do like a biopsy, whether it's CT guided or transbronchial or it's a surgical biopsy, this is something that we do like our pathologists to look at, and what they tend to see are distal airways and adjacent alveoli that are filled with granulation tissue. Generally speaking, this is something that's prednisone responsive, usually over a couple months, probably around 6 months. When we talk about nonspecific interstitial pneumonia, again, this is one of the subacute interstitial lung diseases. This one's a little bit more difficult to evaluate because of the variability of what a ground glass opacity means. So remember what a ground glass opacity is: increased attenuation in the lung with preserved vascular markings underneath. So you can still see the lung tissue underneath it. Again, the etiology is the same. Pathology depends on the stage. If you catch them early, it's mostly cellular, but if you catch them later, it's what we call fibrotic NSIP, and the pathologist will see dense interstitial fibrosis and potentially bronchiectasis, which remember is just persistent insult to that bronchial tube. This is, again, generally fairly steroid responsive unless they're in the fibrotic stage. And again, with all of these, if you do find an offending agent, you want to get rid of that. RBILD and DIP, these are, I think I've seen one person in fellowship with this. What this is generally subacute symptoms. RBILD and DIP, in my mind, are really relatively the same thing. The difference is RBILD is generally upper lobe ground glass nodules or opacities. DIP is generally lower lobe, more diffuse and uniform. IBLD is more patchy. This is definitely smoking related. You have the patient stop smoking and this should just go away and their symptoms should go away. That's obviously a difficult thing to do, but it generally does go away if patients can stop smoking. And you can see what they see right there on pathology. Let's see. So that was supposed to, the CAT, that's the wrong CAT scan, so that didn't change over. But LIP is a lymphocytic interstitial pneumonia. This one's a little bit different, but very, 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 very rare. It's more common in women, generally greater than 50 years old. The symptoms are generally more, not necessarily chronic, but approaching 6 months. And what you see are variable sized nodules, and what you really want to see is thin-walled cysts. So this is the wrong CAT scan, but you see thin-walled cysts. The etiology is Sjogren's, AIDS, lupus, amyloid, and rarely this can transform into lymphoma. So this is something that you usually diagnose based on biopsy. I've never seen this before, but when you do the biopsy, you see that the interstitium and alveoli are filled with lymphocytes. AIP, heme-enriched, this is probably something we've all seen but never actually diagnosed because you treat everything else, because this is the patient who comes in toxic through the emergency room, ends up in the ICU, either on BiPAP, high flow, or on the ventilator. And you can see that their CAT scan looks very similar to just a dense infectious pneumonia, dense pulmonary edema, or ARDS. And so you treat for everything in these patients. Generally, it's an exposure to something, but you never really know and these patients are generally too sick to biopsy. If you did biopsy, you'd see diffuse alveolar damage. The mortality rate with AIP is fairly high. Again, I can't say I've ever seen this before, but I probably have, but you treat them as somebody who's got pneumonia, heart failure, and ARDS. So this is just a different way of looking at the interstitial pneumonias. Again, the acute, so starting from the bottom up, the acute to subacutes, COP and AIP, the smoking-related RBILD and DIP, and then the chronic, subchronic to chronic fibrosing are the idiopathics and the SIPs. Right? So we all get it, right? And it makes perfect sense. So let's talk about a little bit about usual interstitial pneumonia. So this is commonly referred to as idiopathic pulmonary fibrosis, but there's a nuance to this. So usual interstitial pneumonia is generally what we thought of as recently high-resolution CT findings or pathology findings. Idiopathic pulmonary fibrosis has a UIP pattern, but not all UIP is idiopathic pulmonary fibrosis, if that makes sense. For instance, somebody who's been exposed to significant amount of asbestos can develop a UIP pattern on their CAT scan or on their pathology, but is not idiopathic pulmonary fibrosis, it's asbestosis. Same thing with rheumatoid arthritis or collagen vascular disease, and you can see the etiology there. So just a little bit of a nomenclature thing, because the management obviously is completely different. So what we're going to be talking about is idiopathic pulmonary fibrosis, meaning this isn't somebody who's been exposed to asbestos or has collagen vascular disease or had any sort of drug that could cause this. Symptoms are usually cough, dyspnea, but a lot of the times this is an incidental finding, and they're referred to our clinic because they're having chest pain, and then you find imaging findings classic for idiopathic pulmonary fibrosis. The proposed mechanism of fibrosis is, when we start at, I like to do things in reverse. So when you talk about gas exchange, and you remember that simple diagram of gas exchange, the easiest way to think about it is that area generally fills up with collagen from fibroblasts, and so that causes impaired gas exchange, leading to respiratory failure. Why? Well, it's a dysfunction from wound healing, recruitment of immune cells, recruitment proliferation of fibroblasts, which then causes collagen. Why? Because you had some sort of exposure. We don't really know what that could be. These are proposed. Why we all get this kind of exposure, so why do some get that? We don't really know. Maybe we're just living too long. We don't really know. Perhaps there's a genetic component to it. I'm not going to really talk about that, but there's a lot of research going on about genetics with idiopathic pulmonary fibrosis. There's this etiology called short telomere syndrome, and these patients generally have a higher incidence of idiopathic pulmonary fibrosis. But that's kind of the cycle of the mechanism of why patients are fibrosing. The incidence is something that's hard to, I don't put a lot of weight in this slide here, but the incidence is generally it depends on where you look. It's 1 in 100,000 people roughly, but in my opinion, this is probably something that's underdiagnosed. So what's the true incidence? We don't really know. I do think, as an aside, as more people are doing lung cancer screening for 55-year-olds, we're going to be catching this a lot. So it's going to be interesting in 10 years if we give this talk to see if this is going to be a lot more common, and then we're going to catch it a lot earlier, because there's just not a lot of reasons to CAT scan a 55-year-old. But now there is if they meet the criteria. So not a lot of weight, but generally not that common. The incidence in males is generally a lot higher than females. And you can see the incidence starting at the kind of 60-year-old really kind of skyrockets. And again, I don't put a lot of weight into this slide because we don't really know. There's probably more 70-year-olds who are getting CAT scans for whatever reason than 50-year-olds. So hard to really know. Are we just catching it too late, or is this the true incidence of it? I think my guess is that there's probably, should be up here somewhere. So UIP, the prognosis, if you look in the literature, the prognosis isn't great. The estimated survival is really in the range of 2 to 5 years. The reality of it is the progression is very variable. There's nothing in the literature that has told us this patient is going to progress quickly, this patient's not going to progress at all. It's really kind of a guessing game at this point. There are potential risk factors for progression. Obviously, people who are smoking, obviously people who are continuing to expose themselves to things that may otherwise be toxic. Acid reflux is a potential something that may propagate that fibrosis. There's debate in the literature about that. And I mentioned before, genetics probably, if you're interested in telomeres, with that short telomere syndrome. So how do we monitor for progression? Well, fairly frequently, generally about every 6 months or so. Every clinic is different and every patient's a little bit different about how you do have to monitor. We get pulmonary function testing, and what we're really looking there is for their forced vital capacity and their diffusion capacity to monitor for any changes. Imaging, we don't necessarily high resolution CAT scan them every 6 months, but maybe every year we get a CAT scan and every 6 months we get a chest x-ray. There's no guideline, but some sort of imaging to monitor for progression. You could do a 6-minute walk to see the distance that they can go and see if that's getting any different. You measure their oxygenation with that 6-minute walk, and then you measure that at rest and with sleep. And obviously exacerbations. If they're exacerbating and ending up in the hospital, they're probably progressing. Kind of a sad slide, the survival. The 5-year survival for these patients is generally roughly about 20%, and this is just where's my laser? There we go. This is a laser comparing it to other cancers. Unfortunately, the only thing worse than that is lung and pancreatic cancer. Again, my opinion is that this is going to get better over time as we catch it earlier, and we'll talk about catching it earlier and preventing progression. So we talked about pathology and how to define it on pathology, but you really don't need to biopsy these people if the high-resolution CAT scan tells you what it is. And if you have these classic findings on the CAT scan, which is traction bronchiectasis, so think back to what we talked about at the beginning, bronchiectasis, basilar subpleural reticulations, honeycombing, which is absolutely necessary, and absence of ground glass opacities. If you have that on your CAT scan, you can feel fairly confident that this is UIP. On pulmonary function testing, we usually see a reduced TLC, a reduced total lung capacity, forced vital capacity, a preserved ratio, and a reduced diffusion capacity. So it usually looks like a restricted lung, a fibrotic lung. So what's the role of lavage or surgical biopsy in these patients? The paradigm here has generally shifted. When I started my residency, these people got biopsies. As I started my fellowship, this criteria came out, and less people are actually getting biopsied because you can look at the high-resolution CAT scan and feel fairly confident that this is a UIP pattern. So if you don't feel confident, then that's when you would proceed with bronchoscopy or biopsy, just like you would with any of the other interstitial pneumonias. So this is the classic image for a UIP pattern. So you can see the traction bronchiectasis, the subpleural reticulation, and the honeycombing. And notably, you don't see any ground glass opacities. So if I saw this CAT scan in clinic, I would say this is definitely UIP. The pathology is patchy honeycombing. The board term is fibroblastic foci. It's predominantly subpleural. It's heterogeneous, but importantly, it's patchy. So what do you do if you don't really know? Well, it seems silly, but there are entities called probable UIP, possible UIP, or not UIP. When this really just boils down to the presence or absence of honeycombing and or ground glass opacities. So if you don't have honeycombing, it's really hard to say that this is UIP, but I guess it could possibly be UIP if you don't have any features of anything else. So that's really confusing, but that's kind of the guideline that we have to work with. If you do see honeycombing, but you don't really see anything else, it's probably UIP, because honeycombing is generally representative of dense fibrosis. And then not UIP basically means you don't see any features of UIP. Why are you talking about it? You're seeing ground glass opacities. There's different things that are suggesting that it's not UIP. So generally speaking, we're over here. Sometimes we're over here. If I'm over here, if I'm over here, I'm usually doing bronchoscopy and potentially referring to an actual interstitial lung disease clinic either at Mayo or University of Iowa to get their input. So let's say we've actually established the diagnosis. It's definite UIP. So what are we going to do? Well, skipping ahead to right here, the only cure for this is to just take it out, lung transplant. That's kind of a separate issue, a different talk in its own. I think the nearest transplant center for us, Gilman can correct me if I'm wrong, is I think University of Minnesota, and Wash U, I think, in St. Louis. I don't think University of Iowa has a transplant program. I don't know that for sure. But transplant has its own specific criteria and its own, baggage, frankly. The mortality with lung transplant and post-transplant patients is roughly about 5 to 6 years. Or the 50% mortality. That's getting better. But more and more patients with idiopathic pulmonary fibrosis are getting referred for lung transplant and getting lung transplanted, and it really is the only treatment. So if you can't do lung transplant, you're really talking about symptom management, which is pretty much what I do with all of my patients, and it's avoid the offending agent, whether that's tobacco or acid reflux or whatever it may be. Pulmonary rehab, I love. Pulmonary rehab, I describe as, and they're all up there, pulmonary rehab I describe as boot camp for people with lung disease. So if you're trying to get into shape for spring break, we're going to enroll you into this class. It's 12 weeks, and they're really going to push you, and you're going to be able to walk further and feel better. Doesn't do anything to your underlying lung disease, but you're going to feel a lot better. And there's data to corroborate that. And then treat comorbidities, meaning whatever else that may make you shorter breath. If you're overweight, let's try to work on that. If you have heart disease, let's optimize that. If you need inhalers for COPD, let's do that. And then provide oxygen if they need oxygen. This is the criteria for lung transplant. And then pharmacy. We're going to spend a little bit of time talking about pharmacy. There are clinical trials going on all over the country. I believe University of Iowa they have their own interstitial lung disease clinic, so I believe they probably have their own trials too. But we're going to talk a little bit about anti-fibrotic agents, because you've probably heard these medications before. But just a little bit of history about what has been looked at with idiopathic pulmonary fibrosis. You can see it's been looked at extensively, well, maybe not extensively compared to everything else, but it's been looked at, and nothing has ever really helped. In fact, some things have actually been found to hurt. So N-acetylcysteine in combination with prednisone and Imuran actually had a higher mortality, so that study was aborted. But none of these things have really helped. So then in 2014 came pirfenidone and nintedanib. We couldn't have picked easier names for these medications. The FDA approved both of these in 2014. What's important to know, and we'll talk about the studies about these medications, is these medications don't treat pulmonary fibrosis. They can help slow the progression of pulmonary fibrosis. And so that's the take-home point with these anti-fibrotic agents. So this is a study of Lancet. I believe this was in 2011, and this was the capacity trial. I believe this was done in Japan, where they looked at nearly 800 patients with this criteria. They randomized the patients to the medication versus pirfenidone. They gave it at 2 different doses and looked at them for 72 weeks. And what they were measuring is the change in the forced vital capacity. So for time's sake, we won't specifically talk numbers, but this is the placebo group, and you can see that their 6-minute walk, they got worse. Their forced vital capacity, they got worse. But the patients who were on pirfenidone still got worse, but at a much slower, statistically significant rate. For whatever reason, the FDA didn't like that trial, so they wanted their own trial. So at that point, the medication was approved in 2011 in Europe and various areas in Asia, but it wasn't approved here. So then in 2014, this trial was performed. This was published in the New England Journal. They enrolled 550 patients, the same diagnosis, randomized to pirfenidone or placebo, really the same trial. Primary outcome was vital capacity decline. And again, you can see, we'll just look at, for time's sake, change in vital capacity, placebo, pirfenidone. So they still progressed a little bit, but not nearly as fast as somebody who wasn't on the medication. In terms of mortality, there wasn't a defined mortality benefit, but when they pooled all the data, there was a proposed mortality benefit. But there's definitely a progression benefit. So this didn't translate either, but this was the Impulses trial looking at nintedanib. So, sorry, pirfenidone was then approved in October of 2014. The same year, a study was published about nintedanib, and this was relatively the same study, and it was a placebo for 52 weeks looking at their forced vital capacity. And really what they found is, again, a slow disease progression and reduced risk of exacerbation. And so this was also approved in the same year. They have done a follow-up study on these patients, and that disease the slowing of disease progression persisted for 2 years in follow-up. So this is the proposed management for anti-fibrotic agents. So if you have a patient with IPF and they meet these criteria, the proposal is to start one of the two anti-fibrotic agents. There's never been a head-to-head trial as to which one's better, or refer for a clinical trial. If they meet these criteria, refer them for a lung transplant. The guidelines really for lung transplant say anybody who's got idiopathic pulmonary fibrosis, you would send for a transplant referral. This is a very good theoretical slide. Do I do this? Roughly. Everybody's a little bit different. The difficulty in this when it comes to actually clinics practicing in Ames, Iowa, is a lot of the times I don't see patients who have mild to moderate disease. A lot of the times they've had this for a while and we're just catching it now. So they're here, but they're otherwise not great lung transplant candidates. So then we're stuck with going back to here. And the difficulty with these medications is that, one, they usually need some sort of cost assistance program. Two, it's not just something you prescribe electronically and they go to IV. It requires a specialty pharmacy and a lot of paperwork. Three, it can be difficult to take. Pirfenidone is roughly 3 tablets 3 times a day. This is 2 tablets twice a day. They are optimizing that, so it's not 3 tablets, but it's still 3 times a day. And it's fraught with side effects. So OFEV, or nintedanib, there's roughly a 40% side effect rate of developing diarrhea. So now you're asking somebody who's roughly in their 70s with poor lung function, who's short of breath, I'm going to put them on a medication that may slow their progression and give them diarrhea. So in my clinic, it's not something I just automatically go to. What I prefer to do is to see if they have signs of progression. So I watch closely, and usually with pulmonary function testing and imaging, to see if they're going to progress. I haven't been here long enough to have a 6-month follow-up with any of my patients. I had one, and we are looking at getting pirfenidone for them because symptomatically they seem to be progressing. But that's kind of the reality of practicing medicine versus what the actual guidelines should say, because the guidelines say once you make the diagnosis, start them on these antifibrotics and refer them for a transplant evaluation. It's just not always that easy. And so hopefully they just don't progress as fast. When we look at exacerbations, there's obviously a criteria to define who's exacerbating versus not. It's pretty simple, and it seems silly that we have to define this, but to define an IPF exacerbation, one, they have to have an IPF, and it can't be anything else, essentially. It can't be heart failure, it can't be an infection. And so it's an unexplained change in their symptoms, either radiographically or symptomatically. And the management is generally supportive care. There's weak evidence for steroids. We generally give everybody steroids at an undetermined duration. But again, there's a high mortality rate as associated with IPF exacerbations, and so that's why IPF exacerbations is actually an indication for transplant if they're an otherwise transplant candidate. So in summary, interstitial lung disease is a quite broad term. You can usually make the diagnosis on history, lab, and imaging, but if you can't, that's when you go to biopsy or lavage or biopsy. Management really depends on the underlying cause. Most of the time it's remove the offending agent. IPF is rare, but does carry somewhat of a poor prognosis. Earlier diagnosis is better than late, and I do think that we're going to be, again, I think in 10 years we're going to be talking about the average age of diagnosis is probably going to be in the 50s rather than the 70s. And treatment really relies on optimizing functional status, and the early use of anti-fibrotic agents can help reduce the rate of progression, but doesn't necessarily otherwise treat it. So a brief on my resources that I used. All the images were taken from a radiology group in Amsterdam. And any questions? I did have I should note that I had to give the graduation speech in residency, and I forgot to thank my at that time girlfriend, then fiance, and now wife. So now whenever I do a public speaking thing, I have to make a note to thank my wife for all of her help, and she's sitting right there. I just have to embarrass her. So now she can't hold it against me going forward, which she probably still will. But well, thank you. Oh, yeah. Oh, interesting. Yeah, that's interesting. Really in my mind, anything that the lungs just aren't very well protected. So it's exposed to the environment, and whatever your environment may be, exposed to it. Yep.
When you say it's rare, how many do you expect to see in your practice?
So I started clinic in August. I would have to guess that I see 2 a month, and most of them are in their 70s at the time that I'm seeing them. I don't know if you've found anything different. But yeah, if you look at the incidence or the prevalence, whatever data, whatever resource you find is going to give you different numbers. And the truth is, we don't really know. I just frankly think it's probably more than what we think it is. We just haven't. It may just be subtle reticulations that we're otherwise ignoring because it's such a non-specific radiographic finding, and they're 55 and otherwise healthy dentists. So we kind of ignore it, and they got their CAT scan for something else, and they get a CAT scan 20 years later, and it's progressed. That's kind of my non-data driven anecdotal experience. All right. Well, thank you.